All right, chapter 12 is on the primary assessment. So with our primary assessment, we want to focus on life threats. And actually, before I start getting into this, I should really just kind of recap. So to start off our medical assessments, we've got our BSI, we've got our scene safety, we've got our mechanism of injury, nature of illness, we've got how many patients do we have, how many resources do we need, and does our patient need any sort of cervical spine attention? After that, we move on to our primary assessment. So we've got a few different things here. And here, let me actually just bring this up a minute. The book teaches it a little bit different than what I think is best to like learn. So once we do the scene size up here, which is what we talked about, National Registry wants us to do it this way. So the book dives right into this airway, breathing, circulation, which is great. National Registry wants us to do the general impression level of consciousness first. So we'll talk about that here for a minute. So just going off of this general impression, what is that? It's your first impression of what your patient looks like. So you go up to your patient and you look at things like, are they looking at me? Do they appear to be awake? Are they talking already? Do they look okay? Do I see any blood anywhere? Do I notice that, hey, they're vomiting? Or do they look really pale or jaundice or anything like that, right? That all goes into your general impression. It's kind of are they sick or are they not sick? Kind of a first look at your patient. And then your level of consciousness. So with level of consciousness, we divide that into two different sections. For EMT1, we focus a lot on AVPU, AVPU. EMT2, we go a little bit more in depth with Glasgow Coma Scale, or that GCS. AVPU is, are they alert? If they are alert, like they're looking at me without having to be prompted, they're following instructions, so on. Verbal is if, I walk up to them and they appear to be unresponsive, but I say, hey, my name is, I work for such and such, and they, wake up a little bit and look at you or respond, that would be verbal. If they don't do anything, you would then inflict a painful stimuli, like a sternal rub. At that point, if they moan or groan or try and get away from you, that would be a painful response. And if they don't react to any of that, then they are classified as unresponsive. So we go through and we do that. We'll say our patient's alert. Typically, I'll start by saying, hey, my name is Mallory. I work for such and such ambulance. What's going on today? What can we help you with? And they will right away kind of go into their chief complaint. So their chief complaint is what they are telling us. We might have gotten dispatched for chest pain, but when we get there and they say, I'm really dizzy, dizziness is their chief complaint. Certainly, anytime we have that where its dispatch isn't quite matching up with what the patient is saying currently, usually I'll kind of ask them, okay, well, dispatch said you were having some chest pain. Like, are you having some chest pain, or is it mostly just this dizziness that's happening? Just to try and clarify kind of what's going on with them. But chief complaint is what they are telling us. And then we go into our airway, breathing, circulation, and determine transport priority. So let me get the slides back up here. So with our primary assessment, we are focusing on those life threats. Airway, breathing, and circulation are incredibly important. Without those, we don't have life, right? How we go about and when we go about assessing those really determines on the patient's condition, right? If you walk up on scene, they're completely unresponsive, we want to check circulation first, because if they don't have a pulse, we're going to start doing CPR, right? If they are alert, we want to go to airway first. So if they're alert, we're going to do ABCs. If they're unresponsive, we're doing CAB, circulation, airway, breathing. So we'll say that our patient is alert. I go, hey, my name is, I work with such and such. What's going on today? And they say, oh my gosh, I've got horrible chest pain. Well, by them answering our question, we know that they are in fact alert. They're not verbal, or they're not getting that painful stimuli, right? We know the chief complaint, we know they're having chest pain, and we know that their airway is good. Their airway is clear. They're talking to us. We didn't hear any sort of gurgling or gargling noises when they were trying to talk to us, right? That all has to do with our airway. One thing that we need to ask ourselves when we are looking through airway is the airway open? And is it going to stay open? If the answer is yes to both of those, we can move on to breathing. If it's not, if the answer is no, we need to fix that problem and then move on, right? As soon as that problem is fixed. So if you have a really complicated patient, a patient that's taking up a lot of resources, a lot of your time and skills while you're on scene, it's very possible that the farthest you get on your assessment is airway. It's quite possible, right? In fact, a lot of patients, we never make it past the ABCs because we are so focused on fixing those problems. Because without those, with those problems, we don't have life, right? So we got to fix those. So your book talks a little bit about stopping bleeding. For my classes, I find it significantly easier for students to focus primarily on one form of assessment. So we'll talk about the medical assessment for pretty much the most of this class, all except for like about the last week of this class, because medical assessment is the hardest one. I hate to be that black and white about it, but it is. It's the hardest one. Dealing with medical is incredibly difficult because there's so many different outcomes, right? There's a gazillion different outcomes. It could be cardiac, and within cardiac, it could be 7 different differential diagnoses, or it could be respiratory, and within that, it could be 27 different differential diagnoses. Whereas trauma, it's like, okay, we're gonna patch the holes, right? Stop them bleeding, get them to the hospital, right? It's fairly straightforward in comparison. So we focus a lot more on the medical assessment first to get that down pat. And then we start to deal with the trauma assessments. So there's a little bit of difference there, right? So bear with me. We're going to focus on the medical assessments first. Yes, obviously, if they are bleeding a lot, like hemorrhaging, we do want to stop it, but then it's more of our trauma assessment. So we'll focus on that during our trauma. So here we've got that general impression, chief complaint, level of responsiveness, airway, breathing, circulation, and determining priority. So the general impression, sick or not sick. So we're looking at this patient. Somebody called us to a local park. We've got a patient. This is what we see. So again, pause that video if you need to, or we'll just keep going here. So this kid, age is another thing we want to look at when we're looking at general impression. So this kid, to me, kind of hard to tell for whatever reason. It might seem weird, but teeth for me are kind of an indicator that help with age. And she's got her mouth closed. So I mean, if she's got adult teeth, my guess is she's probably 7. If she doesn't, she's probably around 5 or 6, maybe. She's obviously bleeding. That is a whole lot of blood on that tissue. Head wounds do tend to bleed quite a lot. So maybe that's all coming from the head wound, or maybe she's got a skinned up knee. If it's that much blood coming from the knee, likelihood is it's a pretty decent laceration. It looks like she obviously was trying to roller skate around and probably fell and hit her head. So I'm worried about head and trauma, leg trauma. Maybe, if she took a tumble, it's possible that she's got some wrist pain. A lot of kids, or a lot of people in general, fall with their hands outstretched. So she might have some abrasions or maybe even broken bones there. So those are all kind of things that we're starting to think about. Another thing here, and I want you guys to think about this every single time you have a pediatric patient. I don't care if they're 17 and 11 months. Anytime they are under the age of 18, one of the first questions that should come to your head is, where are the parents? Where are the guardians? And how do we get them here on scene if they're not already? So if this particular patient was without her parents at a local park, we need to find those parents. There are rules in place allowing us to transport and care for kids without parental consent, but we need to at least make an effort to get parental consent. That's all kind of, so talking about spinal mobilization. So when we're dealing with C-spine, during this portion of the assessment, we're holding the C-spine still to make sure that they're not continuing to cause problems with their neck. We'll get more into that with trauma as well. So sick or not sick, looking at this patient, sick or not sick? Well, other than the fact that it's a fairly crummy Google stock image, um, looking at this, she looks glum. She's just kind of just melancholy, perhaps, wrapped up in a blanket. She's got kind of a scarf around her, so she's probably cold. She's got what looks like to be a warm beverage, tissues, maybe some medicine here. So big thing with it, but she's awake. So I would say sick, but we're going to talk to her and see kind of what's going on. Big thing here is we've got those medications next to her. Verify that she did or did not take those. The hospital will want to know what medication she took. Tripoding position is a big one. So if the patient is kind of leaning forward, holding onto their knees and straightening their neck out into a sniffing position, that is a tripod position, and it's indicative of difficulty breathing. And then we've got Levine sign, which is that classic, oh, my chest hurts. You're grabbing your chest right away. That's Levine sign. Tripod positioning is one that, we've all seen it, right? We've all probably done it at some point. Imagine like sprinting your heart out at 10 years old on the playground playing tag. Once you get into a safe corner, you kind of stop and put your hands on your knees and kind of look up to make sure that nobody else is coming, right? That's the sniffing position. In that situation, or the tripod position, excuse me. In that situation, you're standing, but oftentimes when it's adult, they're sitting and doing it. So chief complaint is why the patient called us. What is their complaint? This isn't our version of what their complaint is. This is their complaint. So it may be very specific, like abdominal pain. It might be super vague, like I just don't feel well, but it's whatever they are telling us. So with our chief complaint again, smell is something that we do want to take into consideration. Can you smell stale urine? Can you smell vomit? Decay is one of those things that once you smell it once, you know what it is for the rest of your life. It's a very, very specific smell. Hazardous fumes, that's something too, where it's like, just kind of take a sniff and see if you smell anything really weird. Sometimes it might be, they're cooking, who knows, but just verifying that, like, hey, I kind of smell something in here, do you smell that? And making sure that it's not like something like a gas leak. AVPU we talked about, so we've got alert, verbal, painful, and unresponsive. They are only one of those things. So unresponsive, obviously, they're not responding to anything. Painful is they're only responding to painful stimuli. They're only responding to verbal stimuli, or they are, in fact, alert. And then, of course, there are many different types of alert. Typically, we do try and document how alert they are. So are they used to say ANO ×3, alert and oriented ×3. Now we've got 4. So it's person, place, time, and events. So who are you? Where are you? What time is it? And it doesn't have to be it's 4:41 in the afternoon. It's more of a generalized, like, okay, what day is it? What month is it? That type of time, right? Evening, afternoon, that type of thing. And then events. What's going on around you? What is the situation, right? So if they're alert to all of those, they are alert and oriented, ANO ×4. Downside of this is if you say, oh, they're ANO ×2, the next question is, well, what to, right? A lot of people with dementia will kind of forget or have a hard time remembering the time of day and maybe even the events leading up to, but most of the time they still know who they are. I don't want to say most of the time, but that you get the idea, right? It might be one or the other, but that is an issue when using AVPU is, okay, they're not fully alert, but where are they not fully alert? And that's where Glasgow Coma Scale kind of bridges the gap a little bit, and it's a bit more specific. So assessing the airways, or assessing the ABCs, excuse me. Airways first, is it open? Is it going to stay open? Breathing, we're looking at, are they breathing? Are they breathing adequately? And is their breathing rate? We've got that normal breathing rate vital sign, right? 12 to 20 for adults. And then circulation. So with circulation, what's their skin color look like? What's their pulse? I'm missing one. Oh, and then bleeding, if they've got any bleeding going on. And then anytime we run into an issue, we're going to fix it as we find it. So if there's an issue with airway, we're going to fix it before moving on to breathing. If there's an issue with breathing, we're going to fix it before moving on to circulation and so on, right? Fix it as we find it. That is the nice thing about this assessment style, is that it's done in a way from highest priority to least. So we fix as we go, and we don't ever have to kind of go back, I guess, or jump around. So assessing this scene. Looking at the scene, again, pause the video, take a look at it. Starting with our scene size up, it looks like it's a good, well-managed home. We're not dealing with, cockroaches on the floor, that type of thing. No hazards as far as we can see. The patient's downstairs, not upstairs. So unless there's steps outside, we're not really worried about that. We don't see any pets. We don't see any knives, guns, nothing like that. So we're going to assume that this scene is safe to enter. So we enter the scene. We notice that the patient is appears to be unresponsive on the floor. He might be pale. It's kind of hard to tell from an image, but we'll say that our patient is pale, doesn't look well. Our chief complaint is, or our general impression is that he's sick, right? And he's unresponsive. So we'll go up, hey, my name is, can you hear me? What's going on? Maybe give them some painful stimuli. If they don't respond, they're completely unresponsive, and their chief complaint is unresponsive at that point because they can't tell us otherwise. So we'll take a look at airway. Can we look, listen, feel? Are they breathing? Or excuse me, he's unresponsive, so we'll do circulation first. So check a pulse, unresponsive pulse. We go for the carotid. So we're checking here. Do we feel a pulse? From there, we go look, listen, feel. Are they breathing? Is their airway open? Do we hear any gargling or gasping or any abnormal lung or airway sounds? Correct those as we find them, right, and continue on. So I just talked about all of that. So we're checking a pulse. No longer than 10 seconds for checking that pulse. Once we do all of that, we're going to determine the priority for the patient. So determining the priority, we'll take the information that we've gotten so far, and we'll say, this patient is sick. We want to go to the hospital. We're going to do a high priority. This is an unstable patient. We want to go lights and sirens to the hospital. So to do that, we need to, ask ourselves, are we a transporting service? That's one of them. If you don't transport, this is where we call, if they haven't called already, and get another ambulance, a transporting ambulance on the way. We can also take this time to give our radio report to the receiving ambulance. So if there's an ambulance coming, we'll call them quick and say, hey, we've got a unresponsive male patient around the age of 60. Heart rate is XYZ, pulse is whatever, or respiratory rate is whatever, right? And give them kind of a good handoff or a good report so they know what they're getting into. If there's no pulse with the patient, we're going to start CPR and then go down our CPR algorithms. I have been getting a few questions as far as when are we doing CPR? Do we need CPR to start with? I need to work that out with our CPR coordinator. I will get a specific date for us to do CPR. It'll be on one of our Tuesday skills nights. And if you already have CPR, we'll probably have either something else for you to do, or we'll maybe do it after our regular skills, something like that. I'll get it worked out and I'll get the information to you. There's a lot of times where the priority for the patient isn't incredibly clear. You've got a big range, right? You've got patients that are like life or death, need to get to the hospital right now, all the way to like this patient didn't need an ambulance. I don't know why they called. type of patients, right? And everything in between. So it's not always clear whether or not we need to go high priority or low priority with our patients. A big thing that we're pushing in EMS now is our safety is so incredibly important, and going lights and sirens always increases the probability of us getting hurt. Drivers do crazy things when they see an ambulance coming with lights and sirens. I actually just saw somebody blow through an intersection the other day to get out of an ambulance's way. They ran right through a red light, and it almost caused an accident, right? So there's a higher likelihood that you're going to get hurt driving lights and sirens than not driving lights and sirens. So that's something I always take into effect as well, is, you know, if I'm on the fence, maybe we just won't go lights and sirens because of that higher likelihood of us getting injured. If we are transporting the patients, we're going to continue our assessment in the ambulance on our way to the hospital. If we don't transport, we're going to sit on scene with our patient, continuing our assessment and giving care until the transporting ambulance arrives on scene. So patient assessments take different forms. We've talked about that medical or trauma assessments are a little bit different from each other. For right now, we're focusing on that medical assessment. The other thing to note is that people do assessments different ways. Know that I am teaching you the National Registry Standard with a few of my tricks of the trade kind of sprinkled in. That doesn't mean that if you go to your local service and you do ride time or whatnot, that if you notice somebody else doing an assessment a different way, it doesn't necessarily mean that it's wrong. All right. It just, you know, as you go through this and have many different patients, you'll start to develop some shortcuts here and there and everywhere. All right. For right now, I want you all to focus on learning the book way to do these assessments, because that's how you pass your national registry. All right. Stop my recording. That was the end of this chapter, by the way.